Bonjour, welcome to all of you. Welcome to the COVID-19 Immunity Task Force's first town hall event for the general public in Canada. So welcome to everybody. I'd like to thank you all for attending, and I'd also like to thank our partner for this event, Statistics Canada. My name is Caroline Faneuf. I'm Manager of Communications for the COVID-19 Immunity Task Force. Bonjour, mon nom est Caroline Faneuf, directrice des communications pour le groupe de travail sur l'immunité face à la COVID-19. Je voudrais commencer en vous disant que nous offrons l'interprétation simultanée. Vous pouvez choisir d'écouter le webinaire en français, en anglais ou dans la langue originale. Alors, regardez au bas de votre écran et cliquez sur le globe pour choisir la langue que vous préférez. We're offering simultaneous translation today. You can listen in English, in French, or the language that's being spoken at the time. You can click on the globe at the bottom of your screen to select the language. That said, this presentation will be in English today. Je vais aussi vous dire que la présentation sera en anglais. Nous avions donc mis un lien vers une copie de la présentation uniquement en français dans le chat ou si vous voulez suivre la présentation en français uniquement. Et encore une fois, si vous préférez écouter la présentation en français, cliquez sur le globe en bas de votre écran et sélectionnez français. So a few more housekeeping notes. So the webinar is being recorded and will be available in a few days on our website. The chat has been closed to attendees, but you will be able to ask questions. So we do ask that you be respectful of our panelists and the science. You can write your questions in the Q&A section that's different from the chat. It's at the bottom of your screen as well. We'll be taking questions at the end of the presentation, and you'll be asked to type your questions into the Q&A. I'll read through the most I can in the time allotted. So thank you very much. And I now turn it to Tim Evans.
Thank you very much, Caroline, and welcome to everybody. I'm the first of a number of speakers, so I'll just introduce the task force. Next slide. This is the COVID-19 Immunity Task Force structure. There's a leadership group that's composed of volunteers who are experts across a broad set of areas relative to immunity related to COVID-19. We have two co-chairs, one of whom is with us today and will present, Dr. Catherine Hankins, but she's accompanied by Dr. Naylor. We have a number of ex officio members, representatives from Public Health Agency of Canada, Canadian Institutes of Health Research, the Office of the Chief Scientific Advisor of the Prime Minister, and representatives of provincial territorial ministries of health. And the secretary is based at McGill University, where I'm based, and have the opportunity of leading the secretariat. Next slide. The task force was established in April 2020, back at the time of the first wave of the pandemic, seems a long time ago, and with a mandate to support the implementation of research that was relevant to the immunity dimensions of the pandemic due to SARS-CoV-2 and COVID-19. And with a mandate not only to generate, but to make sure that policymakers were informed of results as they arose in order to inform policy. Next. There are four areas of priority research. One is seroprevalence studies, and we'll hear a lot about that today. But there are three other areas that are very important and complementary. First, immune science is really to understand the nature of immunity that's arising from infection or from vaccination. The immune testing, how we get precise measures of immunity arising from infection or vaccination. And finally, and most recently with the advent of vaccines, a whole effort on vaccine surveillance related to safety, efficaciousness, and immunogenicity. Next. Thus far, the CITF has funded 91 studies across the country, and you can see that we go coast to coast to coast in an effort really to make sure that we've got a Canada-wide picture across those 4 areas informing policy. Next. Today we're going to be focusing on results from the seroprevalence work, and really the rationale for looking at serology is that the acute infection testing, which is found through the swabs or the RT-PCR tests, is often is acknowledged to be in many respects the tip of the iceberg with respect to the total infections, and this relates to the fact that that in many cases testing systems have been for acute infection have been limited by logistics and ability of people to access those tests. In addition, we know that many people who are infected don't have symptoms that are severe enough to lead them to getting diagnosed, or have asymptomatic infection. And because of that, the testing for antibodies in the blood, which gives an example, and that gives evidence of past infection, is very helpful in understanding the base of the iceberg. Next. So today we'll present results on what we're calling our most representative study to date, and this reflects the fact that initially we went to more easily accessible sources of data through for example, blood banks in Canada, but we thought at the same time it was very important to initiate a fully representative scientific sample of the Canadian population. So this study results that you'll hear today really provides us that first full picture, Canadians 1 year of age and up, all 10 provinces and 3 territories, rural and urban areas, and both populations who may or may not be in good health. So in total, 11,000 Canadians from across the country participated in this Stats Canada study. Next. Over to Jonathan and Stephen.
Thank you, Dr. Evans. Thank you, Dr. Evans. Hello, everyone. My name is Jonathan Cabot, and I'm an analyst with the Centre for Population Health Data at Statistics Canada that contributed to the COVID-19 Antibody and Health Survey, also known as CCAS. Next slide, please. It has been a pleasure collaborating with the COVID-19 Immunity Task Force, the Public Health Agency of Canada, and Health Canada on this exciting and important project over the past year. We are very excited about our successful partnership that led to the elaboration and implementation of this survey. It's a strong demonstration of StatCan's efforts towards our collective understanding of COVID-19 and its impacts on Canadians and our society. Typically, a survey initiative of this nature would have taken a minimum of 24 to 30 months to plan, collect, and disseminate. Thanks to a strong and coordinated effort from many partners, such as the CITF, Health Canada's Research Ethics Board, the National Microbiology Lab from FAC, other key laboratories, and relevant internal service partners at StatCan, we were able to conduct this survey rapidly and are proud to share the first results from the survey with you today. Next slide, please. So after many brainstorming sessions and consultations with the CITF and within StatCan, CCAS was created with the main goals of better understanding the actual spread of the virus in Canada by estimating the number of Canadians 1 and older who have developed antibodies in their blood nationally and for each province and territory. Better understanding the socio-demographics of those that have developed antibodies in their blood. And finally, to better understand how many asymptomatic Canadians have antibodies in their blood, who they are, and what their symptoms and testing history are. Canadians aged 1 to 24 were selected using the Canada Child Benefit Frame, or a combination of the Child Benefit Frame and the Census Frame. Canadians aged 25 and up were selected with the age order selection method using the dwelling universe frame. The collection of the survey was divided into 4 waves. The first wave was launched with a small sample of around 4,000 to allow us to pilot the survey and have a better understanding of response rates and shipping times. Waves 2 and 3 consisted of the bulk of the survey with a sample of around 22,000 in each, while wave 4 was launched to strengthen the sample representation from Nunavut. Next slide, please. The dried blood spot method was used to determine if respondents to the CCAS had antibodies to the SARS-CoV-2 virus. The pictures on this slide demonstrate the materials used for CCAS. The DBS kits were provided by the CITF, and the CITF, in collaboration with the National Laboratory for HIV Reference Services, initiated an evaluation of several serological testing platforms using a common panel of DBS. From this panel, promising platforms were identified for extensive validation, and 2 platforms were selected to be used for analyzing the CCAS DBS kits. The analysis was conducted by 2 reference laboratories, the Langlois Laboratory at University of Ottawa and the Gingras Laboratory in the Sinai Health System. Next slide, please. Here we see a chart showing the response rates by age. The green line you see represents the response rates of those who completed the electronic questionnaire, while the bars represent the overall response rates, meaning those who completed both the electronic questionnaire and the DBS portion of the survey. The highest overall response rate was in the 8 to 14-year-olds with 28%, while the lowest response rate was in the 1 to 7-year-olds with 18%. Next slide, please. The table and map shown here are the response rates by province and territory. In general, the overall response rates were similar across provinces and territories, ranging from 21% in PEI to 29% in BC and Quebec. The lone exception was Nunavut, which had a lower overall response rate than the rest of the provinces and territories. And now for the results of the CCAS, I'll pass the virtual mic over to my colleague, Stephen Earle.
Thanks, John. Just like John mentioned, my name is Stephen Earle, and I'm going to be taking you through the results of our survey today. We're going to start with the national results overall, by sex, and by age group. So overall, we observed a seroprevalence in the population of 3.6%. That's about 1 in 25 Canadians. 1% of the overall estimate was due to vaccination during the study period, while 2.6% overall was due to infection. Looking at the results by sex, we saw similar numbers, however, slightly higher in females at 3.9% overall versus 3.3% in males. In our survey, females were significantly more likely to report having been vaccinated at this point in the vaccination campaign, and this was reflected in the vaccine-induced seroprevalence that we observed. Females had an overall or a seroprevalence from vaccination at 1.5%, and this compared to 0.4% in males. Because of this difference, the numbers for infection-acquired seroprevalence were again similar, but slightly higher in males at 2.8% overall against 2.4% in females. On the right-hand side of the screen, you can see the results by age group. We observed an overall seroprevalence in the 1 to 19 age group of 3.4%, and almost the entirety of that estimate was due to infection. In the 20 to 59 age group and the 60 plus age group, we observed seroprevalences of 4.5% and 2.1% respectively. And in both of these age groups, vaccinations already accounted for about 1 in 3 people with antibodies. Now, before I continue, it's important to mention that for our 60 plus population in our sample, this included individuals 60 plus living in private households, but did not include 60 plus populations living in institutional settings such as long-term care homes or retirement facilities. Here are the same numbers that you just saw, except broken out by age group and by sex. So what we noticed right away is that in the under 60 population, generally the results are higher than in the 60 plus population. Specifically, looking at working age females, aged 20 to 59, we observed a seroprevalence of 5.1% overall, And this was significantly higher than either of the two age groups 60 plus. And now for the results regionally or provincially. So starting on the top left-hand side of the screen, you can see the results for the territories. We observed an overall seroprevalence for the territories region at 21.1%, or about 1 in 5 of all respondents aged 1 and over in the territories. The entirety of this estimate was due to vaccination. In fact, in our survey, we did not encounter a single individual who had antibodies that were acquired through an infection. Moving down to British Columbia, we observed an overall seroprevalence in that population of 2.4%. In Alberta, the number was 5.6. In Saskatchewan, 4.1. In Manitoba, 3.1. In Ontario, 3.3. And in Quebec, 4.4. In all of these provinces, British Columbia through Quebec, approximately 1 in 3 people with antibodies during the survey period had them due to vaccination. But the same could not be said for Atlantic Canada. First, Atlantic Canada had a lower overall seroprevalence in the population of only 1.3%. And in the adult population in Atlantic Canada, 2 out of 3 approximately had antibodies due to vaccination, as opposed to 1 out of 3 in the other provinces. And this really reflects the good job that the Atlantic region did in general at keeping the virus at bay, at least up until the survey period. So see, these are the same estimates that you just saw, except broken out by sex. Again, we can see trends for results being lower in Atlantic and higher in the territories, again, due to the high vaccination rates that were prevalent at that time. We also see slightly lower results in the British Columbia area. But really what we can see from this slide is that it's hard to discern trends by sex. I mean, we do notice that the only 2 regions or provinces in this slide where males had a higher seroprevalence overall than females were in Atlantic Canada and Alberta. But when you consider the confidence intervals that are around the estimates, which are the gray bars on the table, you see that conclusions are difficult. So confidence intervals are used to express a precision of the estimate. A 95% confidence interval indicates that the true proportion in the population will likely lie between the lower and upper bounds of the confidence interval 95 times out of 100. Looking at the results by province or region and by age group, we can really see the same thing. Conclusions are difficult to determine based on the wide confidence intervals that were observed at this low level of the sample. I mean, we do see that in Saskatchewan and Alberta for the 60 plus population, for example, it is slightly higher. But again, because of those confidence intervals, drawing conclusions can be somewhat difficult. So with that said, we'll turn to our next slide, which focuses on some more national data. We're going to look at other socio-demographic characteristics, for example, occupation risk, Indigenous status, as well as visible minority status in the country. So first, looking at the occupational risk statistic, the first 2 numbers on the left are to orient you, and they are numbers that you have already seen. They are the overall seroprevalence in the population at 3.6% overall, and the proportion of which is due to vaccination at 1% overall. The next 2 refer to jobs which are public facing, or as described in our survey, jobs where individuals report working in direct contact with others. They are observed to have a seroprevalence overall at 5.1%. However, 2.4% overall was due to vaccination. This compares to others who did not report working in a public-facing job, that is, people who reported working but not in direct contact with others, or not working during the pandemic. They had an overall seroprevalence of 2.5%, about half. However, much less was due to vaccination at 0.4% overall. And now the results by population group. Again, on the left, you can see the national numbers to orient you to where we are. The next 2 numbers refer to the Indigenous population within Canada, and this regards specifically Indigenous populations living off reserve or other Indigenous settlements. So we observed a seroprevalence overall at 3.2% within this population, of which 1.1% overall was due to vaccination. This is similar to the statistic on the right-hand side of the screen, the rest of the population, which in this slide refers to the white-only population. So their estimate was 3.3% overall, of which 1.2% was due to vaccination. These numbers compared to our visible minority statistic, which was slightly higher at 4.8% overall. And of that estimate, a smaller proportion was due to vaccination at 0.5%. So if you do the math and you look at the infection percentage for the visible minority population at 4.3%, this compares to approximately 2.1% in the rest of the population, and this difference was statistically significant. So for seroprevalence in people who never got a PCR test. So we asked all participants in our survey if they had ever got a PCR test for an active infection. A PCR test is a nose or throat nasal swab test to look for active COVID-19. And what we found was that in a subgroup of individuals, or in all individuals who had antibodies due to a past infection, 1 in 3 reported never having taken a PCR test at any point in the pandemic. So we followed up on all these Canadians who said they'd never gotten a PCR test and asked them why that was so. And among those, among the people with antibodies due to a past infection, we uncovered that 3 out of 4 reported never having symptoms. And so this takes us to our next slide about topics for further analysis. So these are areas we are looking to explore for further possible analysis, but sample size permitting. So we're looking at the electronic questionnaire and see what other information we can take out of it. For example, we're looking at demographics that were reported within the questionnaire. And we're also looking at self-reported health status, for example, general health, mental health, as well as any chronic conditions. We're looking at COVID-related questions, such as symptoms, tests, vaccinations, as well as any preventative measures that were taken. And we're also looking at the occupation variable. For example, we can take a deeper dive into occupations other than whether or not someone reported working in a public-facing position and look at occupation groups, for example. We're looking at type of household, for example, the number of people that live in a house or the type of house in which they live, for example, a single-family home or an apartment. And we're also looking at household income. We're looking to gain more information out of the dried blood spot test itself. And finally, again, sample size permitting, we're looking at both the electronic questionnaire and the DBS together, looking at, for example, asymptomatic infections by age or visible minority by public-facing work. So thank you so much for your time, and I'll now turn it over to Dr. Buckridge, who is going to lead the next portion of the presentation.
Thank you very much, Stephen. Next slide, please. So I'm going to present to you some work that's being done by the COVID-19 Immunity Task Force to try to pull together estimates from a number of studies. We have on the order of approximately 50 different studies, like the study you just heard about from Statistics Canada, that have provided us with evidence about or information about the seroprevalence in the Canadian population. And so what we're doing is trying to pull together that information with other information we have, such as, for example, from testing through PCR testing, as you've heard about, and other sources, to try to come up with the best overall estimate of immunity in the Canadian population. And the data, the results I'm going to present to you on the next slides are the results of our exercise to do that up until the end of May 31st, 2021, and accounting for immunity that's caused by infection with the virus, as well as immunity caused by vaccination, because those are the two sources essentially, or two ways that somebody can become immune to the virus. I'd like to point out this work is led, as I mentioned, by the COVID-19 Immunity Task Force, and we have support for model development and implementation from Precision Analytics, SeroTracker, and also from faculty at McGill University. Next slide, please. So the method we use, as I kind of alluded to in the first slide, is to really try and triangulate. And so the analogy I like to use, if you think about your cell phone can use the cellular towers to tell you where you are. And if there's only one tower, it can give you a rough sense of where you are. But if it can connect to a second tower, it can give you a better idea of where you are. And if it connects to 3 towers, it can literally draw a very, very accurate point on the ground as to where you most likely are by bringing in more information. And so when I say triangulate, that's what I mean. We want to take obviously more than 3 data points here. We have many data points, but we want to look at the data coming from different serosurveys like Statistics Canada is reporting today, along with data that might come from, for example, deaths due to COVID-19 or hospitalizations due to COVID-19. We want to be able to pull that information together and come up with the best possible estimate of how many Canadians are currently immune to the virus that causes COVID-19. So to do that, we use a statistical regression model, which is essentially a way of just putting that information together into a formal mathematical model. And we're doing this in a way that we compute essentially or estimate the immunity to SARS-CoV-2, which is the virus that's responsible for COVID-19. And we do that in different provinces and territories, and then we link those models together and come up with an overall Canadian estimate. And as I'll show you in a few minutes or a few seconds, that allows us to come up with estimates of overall immunity for Canada as a whole, as well as different regions within Canada. And currently in the model that we're using, we take account of daily deaths occurring in each region, the age distribution and the sex distribution of deaths in each region, and also, as I mentioned, on the order of about 50 different seroprevalence results, from 50 different seroprevalence studies, many of which provide results for each province and territory, like the study we're hearing about today for Statistics Canada. And finally, we also take account, as I mentioned, of immunity through vaccination by using data coming from the provinces on the vaccines delivered and the types of vaccine delivered. Next slide, please. So looking for immunity induced by infection with the virus only, or natural infection, as you may call it, in Canada, this is the result we get. And just to orient you to the plot or the chart you see on the left, along the bottom, you can see the time or dates. So we're going, as I mentioned, up until the end of May with our current estimates, and we're starting right back from the beginning of the pandemic. And on the axis going up, the vertical axis, you can see the cumulative percent of the population seroprevalence. And so what the line is showing you is the very dark line in the center is our best estimate. And then the darker shaded interval around that center line is our 50% credible interval or confidence interval, exactly as the way Stephen described it. And then the light area outside is our broader or 95% credible interval. And so that center line you see at the end of May is telling us that 5.3% of Canadians from our modeling have immunity to SARS-CoV-2 through natural infection. And this result, just to point out in relation to the result that you heard from Statistics Canada just a few minutes ago from Stephen and his colleagues, is looking a little bit later in time because Statistics Canada's study was sampling more in January and February, and this is in later May. And also we're bringing in different sources of information in addition to that one study, so it's understandable that our estimates might be slightly different. Next slide, please. Now, if we also account for vaccination as a source of immunity, we end up with the results you see here. And the plot is very similar. We have time again along the bottom, and we have the cumulative percent seropositive or with immunity through seroconversion on the vertical axis. As you can see, the numbers on the vertical axis are much higher. And in fact, the red area that you see on the plot here is exactly the same plot I showed you on the previous slide. So that's the proportion of the population in Canada that we estimate has immunity from infection with the virus. What we're adding in here, though, now is data from vaccination, which is the blue or the teal area you see on the plot. And so as you can see, starting, of course, in early 2021, the number of people vaccinated started to increase quite quickly, and that increased quite quickly, of course, the number of people with immunity from vaccination. Now, the white or gray area you can see in behind is really the sum of those two, accounting for some degree of people who were both infected and vaccinated. And that gives us our overall estimate of the total number of people who had immunity either from infection with the virus or vaccination by the end of May 2021 as being approximately 45%. Next slide, please. As I mentioned, we come up with that Canadian overall estimate by first fitting models that are linked to different regions of Canada. And so what I'm showing you now are the model results in the same way as I showed that previous plot, which shows you the red area for natural immunity, vaccine-related or induced immunity in the teal or blue area, and the white area being the overall immunity. We're showing you those results now for Alberta on the left and Ontario on the right. What's a little bit different about these plots, though, are you can also see now these black dots that have been added. And these are actually the results of individual serosurveillance studies. The estimates, for example, as you can see, the arrow there is pointing in both of those plots to the particular estimate that was provided by the study you just heard about from Statistics Canada. And so you can see that those estimates, what the model tries to do is again, triangulate between those points and the other data that I was talking about, which is not shown directly on this slide. But this gives you a sense about how those different data fit together. And the vertical blue areas going up over each dot, those give you a sense of the time range over which the serosurvey was done and some sense of the temporal support, if you will, of those estimates for the overall triangulation effort. So next slide, please. I can show you two other provinces as well. Here's Manitoba on the left, and on the right, the Atlantic provinces, where we've grouped together, again, the provinces in the Atlantic region, mainly because, of course, they did not have a lot of infections, and so we had to bring them together to get a reasonable estimate. But the reason I'm showing you these two is you can see on the left that Manitoba is a very large proportion of the population that has immunity through infection with the virus. That's the red area. Whereas in the Atlantic provinces, you can see that there's virtually no area there, or very few people that have immunity through infection with the virus. However, when we add in the vaccination, which is the teal area, you can see that those two regions are become quite similar. We still see a higher level of overall population immunity in Manitoba at 47.5% compared to approximately 40% in the Atlantic provinces. But it's important to understand that the proportion of immunity coming from vaccination is much higher in the Atlantic provinces, for example, compared to Manitoba. Next slide, please. So to summarize, the work that I've just presented on this immunity modeling is really about this triangulation effort. So trying to pull together different sources of information to come up with our best overall estimate of immunity in Canada and by regions. Our initial estimates, as I've shown you, indicate that there are, generally speaking, low levels of immunity in the population from infection, but there is some variation across geographical regions in the immunity due to infection with the virus. However, vaccination is now the main source of immunity in all regions of Canada. And we will continue to do this synthesis work, trying to triangulate from these different sources and producing these estimates to give guidance about the level of immunity in the Canadian population, accounting for all these different sources on a monthly basis from the task force. And that will allow us to incorporate new data as they become available and also to bring in refinements to our regression modeling approach. So with that, I will now pass the podium, virtual podium as it is, back to Dr. Kate Henkes.
Thank you, David. And I just want to say first, what a privilege and a pleasure it has been to work with the Statistics Canada team. They brought to the table vast experience in survey methodology and the statistical expertise that is world renowned. So let me just start with the conclusions from this study. So CCAS shows antibody levels were very low going into the third wave. We were sitting ducks for what would happen. Children and adolescents were more likely to have infection-acquired immunity than Canadians 60 years and over living outside long-term care, which meant that those Canadians were really protecting themselves. Those 60-plus community living Canadians were physically distancing and using masks. Public-facing workers had more infection-acquired immunity and vaccine-induced immunity than others. Many of them came up first in terms of priorities after long-term care residents for vaccines. And Canadians belonging to visible minorities were twice as likely to have infection-acquired immunity and half as likely to have vaccine-induced immunity than others. Next slide, please. And then if we look at asymptomatic infection, this is quite concerning. When we look at it, 1 in 3 Canadians that had antibodies from infection had never had a PCR test. So actually didn't know they had confirmed infection. And 3 out of 4 of those, they didn't take that test because they had no symptoms. So about 25% of Canadians who tested positive for antibodies due to a previous infection had no symptoms and could have spread SARS-CoV-2 unknowingly to others. This really reinforces that physical distancing measures and mask wearing have been the best ways to control the virus before the vaccine rollout began, and they'll play a role going forward. Next, please. Now, the Statistics Canada results, they help us understand those from other task force funded studies that might have had participation biases. So this is a really helpful framework for you, as David has shown. If we look at a good place to find out what's been happening in the world, you can go on our website and look at SeroTracker that's been mapping global seroprevalence data. And they've done a recent systematic review and meta-analysis that was published showing that the median seroprevalence in 74 countries was 4.6%. So Canada was about the same, in the middle of the road there. Next. So if we look at all of the studies so far, what we're showing is that immunity from infection will not be enough. In fact, nowhere near enough. Vaccines are critical, especially when we're faced with variants such as the Delta, which is more transmissible and potentially more severe as well. We're seeing SARS-CoV-2 infection more commonly found in visible minority communities, in poorer neighborhoods, in public-facing occupational groups, and in younger age groups. So we really need to double down on our efforts to increase vaccination rates in these populations. First dose, and then following up with the second dose. Next, please. Serosurveys continue to be important to measure waning immunity. They can detect antibodies due to infection and due to vaccination and measure waning in immunity by age group. This will help inform timing of potential boosters down the road. Next, please. I want to speak just briefly about dried blood spot antibody testing. Next slide, please. The task force initiated and funded a validation exercise to look at dried blood spot specimens because they would be great. They would help avoid blood draws and having to go to clinics. This was done, coordinated by the National Microbiology Laboratory, and the participating sites were Vancouver, Toronto, Ottawa, Montreal, and Winnipeg. And comparing commercial assays with the bespoke Made in Canada assays, the Made in Canada assays performed the best. And you'll hear shortly from Anne-Claude Gingras and Marc-André Landroy about their work. But the dried blood spot specimens are permitting studies in populations such as Statistics Canada, as we've seen, pediatric populations, Indigenous peoples, the CanPath study, correctional settings, and many other. It helps us obtain more representative samples and increase participation rates. Next, please.
Hi, I'm Marc-André Langlois, head of the Langlois Laboratory at the University of Ottawa.
Hello, I am Anne-Claude Gingras, head of the Gingras Laboratory at Sinai Health in Toronto.
It's important to know how many Canadians have antibodies to SARS-CoV-2, the virus that causes COVID-19, as this suggests they have some form of immunity. Testing for antibodies with dried blood spot kits has proven to be a highly effective way to test blood samples from hundreds of thousands of Canadians all over the country.
Both of our laboratories are among those that have played a very important role in analyzing the dried blood spot samples shipped from all over Canada. We have both developed assays that test for the presence of antibodies to the SARS-CoV-2 virus. These assays have already been used on more than 100,000 samples from across the country.
An at-home collection kit is an easy way to collect blood from large numbers of people. The participant simply pricks their own finger with a lancet and applies the blood onto a filter card that has 5 circles. Once dry, the card is then mailed back to the lab for analysis. The first step is then to punch small 3mm discs from a spot using a semi-automated puncher that transfers 2 of these punches into a single well of a 96-well plate.
A buffer solution is added to each well to release the antibodies from the dried blood punch.
These antibodies are further diluted by a technician and transferred to an automated platform. Each sample is checked for the presence of antibodies against 3 different SARS-CoV-2 proteins. These proteins are produced in large quantities by the National Research Council of Canada. Using 3 different SARS-CoV-2 proteins not only increases the specificity or exactness of the test, but it allows scientists to accurately determine if a person has antibodies due to a previous SARS-CoV-2 infection, or due to vaccination, or both. Each system can perform between 3,800 to more than 4,800 individual tests per day.
The automated instrumentation performs each step of the experimental procedure using a liquid handler that adds specific reagents at different points.
The last reagent added will emit light if antibodies are present in the sample.
At the final stage, the plates are read in a detector. The amount of light detected tells how many antibody to SARS-CoV-2 proteins are present in the sample.
Our 2 teams have worked closely with the National Microbiology Laboratory, the COVID-19 Immunity Task Force, and the National Research Council to create this made-in-Canada solution. This work helps us better understand the spread and impact of the virus among Canadians and their immune response to vaccination.
So, merci beaucoup à tous nos présentateurs. It's now time to open this up to your questions. So again, you can use the Q&A portion at the bottom of your screen to go and type in your questions. If you'd like to ask the question to one of our speakers in particular, please add their name. As we have we have some questions already, and we do have limited time, so we'll try to answer as many as possible. You can ask your question in English or in French, and we will answer it in the language that you choose. So there you go. Joining us for the question and answer period actually is Dr. Marc-André Langlois, who is head of the Langlois Laboratory that you just saw in the video. So in case people have questions about the actual testing mechanisms, he is here as well. And of course, joining him, Dr. Catherine Hankins, Dr. Timothy Evans, Dr. David Buckridge, Jonathan Cabot from Statistics Canada, and Stephen Earle from Statistics Canada as well. So, first of all, for the link to the English PDF, so we will be posting that on our website, covid19immunitytaskforce.ca, very shortly. So please go to our website. Under resources and presentations, you'll find it there. So one of the questions that we have, there have been over 80 seroprevalence studies comparing adults to children, and most have found higher seroprevalence in adults. Given how close the estimates were in this study, do you feel the difference you found was real? So Stephen, do you want to take that one?
Sorry, just finding my unmute button. So the Statistics Canada sample was representative of Canadians 1 and over. And so really the estimates that we're seeing are likely true within the confidence intervals that are provided for the estimate. I can't speak to other serosurvey studies and what their methods were, but our study design was such that the estimates would be representative of the national population for the age group specified. So that's about as far as I can go with that.
All right, I know Tim and Kate both have something to add. So Tim, do you want to go first?
Yeah, first is the study that was referred to is actually a study from SeroTracker, which is, as Kate mentioned, is one of the CITF-supported investments to really synthesize seroprevalence studies globally. But actually, the finding in that study was that seroprevalence in the age group 18 to 64 is higher across all those studies than it is in people over the age of 65. And so that's what that synthesis found. It didn't comment specifically on seroprevalence in children. The other factor is that study was done in the calendar year, for studies done in the calendar year of 2020. And what we found over time is seroprevalence has evolved as the epidemic has progressed. And younger populations have become more prone or have been accounting for the bulk of the infections. And I think the timing of the StatCan study corresponds with that bigger picture shift in the epidemiology.
Thank you, Tim. Kate, did you have anything to add?
Yes, just to say that if you look at the confidence intervals, you'll see that for the 1 to 19-year-old age group compared to the 60-plus age group, those confidence intervals do not overlap. So that is a statistically significant difference.
All right, thank you, Kate. The next question, I believe, actually is for Marc-André. What antibodies were detected and what methods were used?
So it's a classical ELISA. So the antigens were produced by the National Research Council. Both laboratories used the same identical antigens. And the antibodies detected were IgG against the spike of the virus, the nucleocapsid, and the receptor binding domain.
Thank you, Marc-André. Stephen, for you, what proportion of the seropositives due to infection had a prior positive PCR test? The comment is, given lower participation rate, this is an important potential source for bias to consider.
Yeah, so in our survey, the proportion of the people who were determined to have a previous infection who also reported a positive PCR test was about 55%. So about 1 in 2 people. And yes, to that comment, we did observe a low response rate. It's certainly lower than we had expected or hoped for. However, our methodology teams worked extremely hard to kind of adjust for the non-response that we saw in the survey.
Thank you, Stephen. So the next one could go to a few people. It could go to Marc-André or Kate or Tim. How is immunity from infection versus vaccination determined?
I can jump in. So we surveyed several antigens. So the nucleoprotein of the virus, antibodies directed against the nucleoprotein are indicative of a natural infection. So the vaccines that are currently deployed in Canada do not elicit antibodies against the nucleoprotein. So that is how we determine natural immunity. So an individual needed antibodies against both the nucleoprotein and the spike protein.
Thank you, Marc-André. So an interesting question, I'll ask Kate this. When will the citizens of Canada have access to the excellent antibody tests you used in the study, and private pay is assumed?
That's interesting because obviously we get quite a few questions coming into the task force saying, can I participate in a study? When can I get access to my own antibody results? We do know of a few private companies that are offering this. We don't know what the standard of their performances and their tests and so on. So for the moment, antibody tests are not yet available. The task force is working hard to try to figure out what are the thresholds for protection. So we're looking over time at what happens to binding antibodies, what happens to neutralizing antibodies, and what happens to cellular immunity.
Thank you, Kate. Did you test only for IgG antibodies, or did you measure IgM as well? So I guess that could go to Marc-André again. I think you answered that already, but in different lingo.
So no, we did not measure IgM. We simply measured IgG.
All right, thank you, Marc-André. How do the DBS seroprevalence studies compare to plasma collected seroprevalence studies? Not sure who to ask that to. Tim or Kate, do you want to jump in there?
I think Marc-André might want to talk about, what are the specific challenges to do with DBS and how they compare to if you have a serum sample.
So we've actually compared matched samples that were collected with DBS and the matched serum samples. And the sensitivity of the assay is similar for seroprevalence studies.
Thank you. The results from the study show that immunity is higher in minorities and younger populations. Could this be due to a stronger and longer lasting antibody response in younger populations than in older populations? Kate, do you want to take that one? So that immunity is higher in minorities.
There's both the possibility for differential immune responses, but also for differential waning in antibodies. So I don't know if Marc-Andre wants to talk about that. We can't really adjust for that at this point, given our current knowledge, to look to see, in particular with the nucleocapsid antibody, is it waning over time and is that affecting results? So this is something we're learning more about all the time. Marc-Andre, do you want to comment?
Certainly. So the nucleocapsid antibodies do wane a little bit faster than those directed against the spike. However, there's also another parameter that is important is what kind of exposure an individual has had. Was that immune response a potent one or a weak one? So they may start with already a lower level of antibodies against nucleoprotein. So the N antigen is slightly a more difficult analysis. However, what we can say is through all the samples that we analyze of early infections, we can still detect anti-N antibodies even now in more than 1 year into the pandemic.
Thank you to both of you. And I think we only have time for one last question. Tim, I'm going to ask you, if you have antibodies, do you need a vaccine? In studies, it has been shown that you are as much immune, even if you had it, than with a vaccine. So why is vaccination necessary for those who already have antibodies due to an infection?
This is a great question. I think when the first is that the part of the response is that the COVID immunity task force has supported studies to understand what the duration of protection is from an infection. And those studies now, which have been going on for just over a year, suggest that from symptomatic infection, you have a robust protection of between 10 and 12 months. So those studies are continuing, and we may find that protection actually goes beyond that. However, when vaccines were introduced, we only had about 6 months of follow-up. And it was clear even then that the protection wasn't absolute, especially for people who may have had asymptomatic infection, where it wasn't as clear that the immune response is as strong. And those were not being followed in longitudinal cohorts. So I think policymakers thought, well, we better make sure everybody has access to vaccination, given the uncertainty related to protection arising from infection. However, after first dose of vaccines, for those who have had previous infection, we see a very robust immune response, so strong that, in fact, recommendations have been that those individuals do not require a second vaccine. And that's what happened in the province of Quebec. That was the recommendation that a single vaccine following symptomatic infection, you would have very good protection. However, when it comes to vaccination, individual preference comes into it. And a lot of people, even if they've been infected and had a single dose, would also like to have a second dose, especially because of issues related to travel, where double vaccination is being seen as a requirement, independent of whether you had previous infection. So I think for all of those reasons, it's very difficult to draw a very clear line in the sand with respect to how to manage individuals who've had previous infection, other than the fact that it's very important to note it and keep it in focus, because we know that it is a significant driver of your immune protection, whether you're vaccinated or not.
Thank you very much, Tim. I want to thank all our panelists today. Thank you so much for your time. And I want to thank you very much for joining us today. It really was our pleasure to have you join us in this Zoom webinar. Once again, the French presentation is available in the chat. My colleague Rebecca has also put a link up to where the presentation in both English and French will be by tomorrow. In the next few days, you'll also find the webinar itself, both in English, and then the version with simultaneous translation in French will be on the same page on our website. So we at the COVID-19 Immunity Task Force plan on organizing more such presentations this fall, and we'd love it if you could join us. So please follow us on social media or keep tabs on our website to make sure you get the invite for our next presentation. Encore une fois, la présentation en français est disponible dans le chat. Et puis, ma collègue Rebecca a aussi mis les présentations, le lien vers notre site web où les présentations en anglais et en français vont être d'ici demain. La vidéo de la présentation du webinaire va aussi être disponible dans quelques jours sur notre site web à cette adresse. Alors, nous vous souhaitons un très bon après-midi ou fin de matinée, dépendamment de où vous êtes au Canada. Have a great afternoon or rest of morning from wherever you are in Canada. Thank you for joining us. Bye.
Merci.